Park's invitation. And I'm very excited to share my materials with all the colleagues. The topic I'm going to share today is orthodontic turning point from failure to success. I'm Johnny Liaw. I'm from National Taiwan University and also from Taiwan Association of Orthodontists. Just like to give you an idea where Taiwan is. Taiwan is a small, beautiful island surrounded by China, Korea, Philippines, and Japan. And the city I stay is Taipei, which is the capital of Taiwan, and also where the highest building, the Taipei 101, is located. As an orthodontist, the Taipei 101 looks like a minuscule to me. I hope I can convince you the value of tests in our daily practice. Excuse me, can we minimize, okay, the here? Okay. Again, I'd like to extend my most sincere gratitude to the organizer, Dr. Park, for his kind invitation, and also this opportunity to share my materials with all the colleagues. Back to my topic today. I'd like to focus on some critical decision making in our daily practice. Here this is the theme of 2020 TAO annual conference. Actually, after the last overseas international conference I have attended is 2020 annual meeting in Portland, United States. After that, it seems everything locked down. And AO annual meeting is the first to go virtual. The first ever in AO history. And after WIOC in 2019, the 2020 WIOC originally was planned to be held in Peking, China, but it was disappeared without any announcement. The ninth IOC in Yokohama, Japan, at last go virtual in the end. So everything seems locked down. It makes me recall all the orthodontic journey in my past decades. I recall all the wonderful experience in so many international conferences, not only vibrant scientific program, but also beautiful sceneries and warm friendships in various locations in different countries. So when I got this invitation from WebCeph, I decided to review all the topics I have gave in the past and decided to present an essentials of my past presentations. So here I have the orthodontic turning point from failure to success for you. And I'm trying to focus on the critical parts, the most critical parts, which lead to success instead of failure. Because I think orthodontic treatment is all about countless decisions made in every appointment. Just like everyone's life, it's all about countless decisions made in everyone's journey. It was 2000. It was 2000 when Dr. Zhang Lin invited Dr. Hee Moon Kyung to give the first TED presentation in Taiwan. And after that, Taiwan is lucky enough to host the third AIOC and the sixth AIOC and the second WIOC, the World Implant Orthodontic Conference. So after that, the third WIOC was held in Verona, Italy. And I spoke on total arch digitization with tests. Here we have the first our first case today. She was a low angle class 2 division 1. We know this kind of low angle case usually have strong muscle, and which make the tooth movement more difficult than average manual plane angle. So I tried to use tests to digitalize the whole upper arch, trying to avoid extraction to improve her protrusive profile. Here we have, you can see the upper posterior tests were installed to retract the canine to digitalize the whole upper arch. And in addition to upper posterior tests, I also installed the lower posterior test to upright the lower incisors, because if we do not upright the lower incisors, there is no room, no overjet for us to retract the upper incisors. And one more thing we need to know, we need to open the deep bite before overjet reduction. So I installed the anterior test in the lower arch between two central incisors so that I can digitalize upper and lower at the same time while I open the deep bite. And here is the treatment comparison. Without extraction, we can improve this protrusion by total arch digitization. And with 4 tests at 4 quadrants, we can easily correct the dental midline. And you may notice the smile view. We can see the smile improved, the incisor show improved, because the torque of upper incisor were too proclined. So we need to upright the upper incisors to improve the incisor show. And that's why I installed the lower anterior test instead of upper anterior test. And here is the Zipperometric Superposition. You can see no extraction, but we can digitalize the upper arch by 4 millimeters at molars and 8.8 millimeter at incisors. And here is 10 years follow-up. The profile look stable, no problem. So you can understand with the help of tests, we can do total arch digitization in class 2, especially for low angle cases, because we do not want to extract. How about class 2 division 2? You can see a protrusion class low angle case with a gummy smile, and the deep overbite was over 100%. So again, I use upper posterior test for class 2 correction and anterior test for bite opening and gummy smile correction. Together with the bite table here to disocclude. When we bond the lower brackets, we use an upper posterior test for class 2 correction and the anterior test to open the deep bite successfully. My preference for the anterior test is subapical. With the anterior test, you can see we can open the deep bite like this and reveal the worn incisal edge so that you can restore the worn incisal edge. At the same time, we can use the upper posterior test to distalize the upper arch to correct the class 2 canine relationships. And here is before and after. Before and after. The torque was well controlled. Before and after. The molar relationship were complete class 1, very solid class 1. And also the facial profile was improved. And the gummy smile was corrected. I'd like to thank a good friend, Dr. Ronsi from Thailand. He drew this illustration to show the combined intrusion and retraction force system for this case. And he also drew the Zipperometric Superposition to show the treatment changes. We can see the total arch distalization in the upper arch so that we can reduce the facial profile. With the incisor intrusion, we can also correct the gummy smile. Without extraction, the upper arch was distalized in mass. In addition to the torque band in the incisor slots, we also use upper anterior test. We can intrude the upper incisor, but at the same time, we got a counterclockwise rotation. The counterclockwise moment, which means plateau root torque for this case. So we can correct the class 2 dip 2, the retroclination of the upper incisors. So total arch distalization with test also works well in class 2 division 2 cases. But I'd like to show you another class 2 division 2 case, which did not go so smoothly. Again, a low angle case. Class 2, dip 2, deep overbite, over 100%. We suggest the removal of the wisdom teeth. And he got posterior crossbite, anterior deep bite. So upper posterior tests were used to retract the upper dentition, trying to correct the class 2. But we need to open the deep bite first. So we install anterior tests on both arches. So after the bite was opened, we distalize with the test to retract the canine and incisors to correct the class 2. However, the relationship looks still a little bit class 2. However, if the test fail, what would you do for this kind of difficult case? I asked the patient to wear class 2 elastics. However, because we need patient compliance for elastic wearing, so I prefer using tests instead of class 2 elastics. So I inserted plateau test in conjunction with the modified plateau test. Although we try for 1 year for upper arch, total arch distalization, but still, there was still canine class 2 on the right side. So finally, I decided to insert another buccal shelf test, but I slanted the buccal shelf test forward so that I can attach power chain from the terminal molar to the buccal test. And then you can see I can protract the lower dentition forward so that I can get my buccal interdigitation to solid class 1. Here is the treatment comparison. What I'm trying to explain is there must be boundaries for tooth movement. There must be boundaries. We do not know where the boundary is, but we just try total arch distalization first. But what would you do if you cannot distalize the upper arch anymore? I decided to protract the lower to match with the upper. Here is the OPG, look good, and the Zipperometric Superposition showed upper arch distalization. And I can protract the lower anteriors to match the upper dentition. So maybe you need a plan B for every case. If the treatment strategy does not work well, we can continue the treatment. The next 2013 AO meeting in Philadelphia, I shipped to class 3 treatment with tests. I tried to apply total arch distalization in class 3 treatments. I think for class 3 treatment, extraction or non-extraction, that's a problem, especially for class 3 cases. Why is that? Usually, we prefer to retract the lower for class 3 correction. But the reality sucks. It tends to advance the upper dentition to become a protrusive facial profile after anterior crossbite correction. So like this case, a class 3 moderate protrusion, not very severe, but the lower dentition, there was no crowding at all. So I tried to use self-ligating bracket to align the very severe crowded upper arch. The treatment proceeded very well, so we can correct the anterior crossbite in 4 months. Then class 3 elastic correct the class 3 malocclusion very fast in 8 months. So here is the comparison before and 8 months. We can see the occlusion-wise, it looks good, but the facial profile became a little bit protrusive. At last, the patient decided to remove 4 bicuspid so that she can get a better facial profile in the end. Here is pretreatment, non-extraction, and here is the result of extraction. But a similar case, you can see not much crowding in the lower arch, but severe crowding in the upper. I decided to remove the lower wisdom teeth, then expand the upper arch and retract the lower dentition with tests. You can see the anterior crossbite was corrected successfully. However, when I correct the anterior crossbite, the facial profile became protrusive like this. Of course, we can extract 4 premolars, but this time I chose to add 2 upper posterior mini screws to retract the upper arch. And with the lower test, we can distalize both arches at the same time to achieve the facial harmony in the end. If we compare the Zipperometric Superposition, you can see when we correct the anterior crossbite, most of the tooth movement was achieved by upper anterior flaring. And after I install the upper posterior test, I can continue to distalize the lower dentition, and at the same time, I can distalize the upper dentition so that I can get the ideal facial profile after I finish this case. And here is the Zipperometric Superposition. You can see the black initial, the purple after anterior crossbite correction, and in the end, the red indicates we retract the incisor back to restore the original position, but the net effect is lower dentition digitalization to correct the anterior crossbite. So with the test to digitalize the lower dentition and also upper dentition, we can maintain the facial profile and improve the facial profile after the anterior crossbite correction, which leads to temporary protrusion. However, of course, the diagnosis is the most important one. You can see a very similar case. Not much crowding in the lower, only a little bit on the upper. So I decided to remove the wisdom tooth on the upper and retract the lower dentition with TAS. After anterior crossbite was corrected, we continue to retract the upper with upper posterior TAS. Although the occlusion looks good, but the patient complained of steel protrusion. This was not what he wants. So we decided to remove 4 premolars and close all the spaces to improve his facial profile. So let's compare pretreatment, non-extraction, and extraction. I think the patient was right. I like the profile better. So for any treatment strategy, you need to be very careful of the indication, diagnosis. So extraction and non-extraction, I think is just like the pendulum, swing back and forth. You need to be very careful, and you need to communicate with the patient to see what he or she wants. I'd like to share you another dilemma case. Because this lady asked for retreatment because she got her orthodontic treatment during her adolescence. You can see the lower first premolar were extracted in her prior treatment, but she complained of protrusion. I think that is because the late mandibular growth after orthodontic treatment. So I decided to remove the lower first molar to close the space. Then we will retract the lower dentition. What about upper? In class 3 cases, I hesitate to extract in the upper arch. So I just try to digitalize the whole upper arch with TAS. So here we will go. You can see I remove the lower first molar and retract the lower dentition. Retract the lower anterior to close the space, but I need the upper posterior TAS to digitalize the whole upper arch to keep ideal overjet. When we close most of the spaces in the lower arch, one day I noticed the root looked so obvious through the lingual mucosa. So I decided to stop the lower retraction and close the spaces by protracting the lower molars using the TAS. I use subapical TAS with the extension lecture wire to hook the terminal molar and forward. And also use class 2 elastics. So I finished this case like this. Looks like the lower second molar replaced the first molar. All the others look basically the same, but the better interdisciplinary, of course. And we can see the lower incisors became more upright, retracted, so she got better, less protrusive facial profile. The OPG looked not bad. And here is the Zipperometric Superposition showed a large amount of lower incisor retraction. For the upper, we can use the upper posterior test to distalize the whole upper dentition so that we can keep the ideal overjet after we close lower first molar spaces. But we had better be careful about the periodontium. You can see the lower incisor, the root of the lower incisor seems a little bit out of the alveolar trail, which is very dangerous. You cannot retract it all the way. Maybe you need to be careful monitoring the alveolar housing. If the root were still within the alveolar housing. If not, we had better stop and change the direction of tooth movement. Not all the spaces were closed by retraction. So that was for my 2013 AO presentation about class 3. The next is WIOC. In the same 2013, we got a large group of delegates to promote the first Taiwan International Orthodontic Forum in 2014. My topic is top case made easy with tests. And I shift to my focus on protrusion cases. That is, some cases might be so difficult beyond maximal anchorage because so severe protrusion. You can see quite severe protrusion, and we plan to remove 4 bicuspids, of course, but unfortunately, she got hopeless lower left second molar, and for the lower right, I think the first molar is poor. So I decided to remove these 2 molars in addition to 4 premolars. And also I plan to remove the upper wisdom teeth. But after extraction, when we bonded all the appliances, you may notice so much space in the lower arch. So we can imagine the overjet would be increased a lot when we close all the spaces because the anchorage. So we need to reinforce the anchorage in the upper arch. Using the upper posterior test, we can distalize the whole upper dentition to catch up with the lower incisors to keep ideal overjet when we close all the spaces. And we can improve the facial profile like this. Actually, before I use tests, I cannot imagine this kind of treatment result. If we look at the Zipperometric Superposition, we can see a large amount of incisor retraction. There was no anchorage loss at all, and after complete space closure, we can distalize the whole upper dentition. And we can close all the, I think the spaces we close in the lower dentition per site is more than 20 millimeters. So that is really amazing to me. Another protrusion case, we can see a lot of prosthesis, including a cantilever prosthesis with the upper left lateral incisor missing. Besides that, we may notice here a hopeless upright first molar. So full premolar extraction plus wisdom teeth removal and this hopeless molar. So with the ascetic pontic hung on the arch bar, we got each premolar, one premolar space on each side and one extra first molar space on the upper right. You know, during the space closure, there will be a tendency for the upper dental midline to move to the right because on the upper right, there was an extra molar space there. But with the upper posterior test, we are able to maintain the dental midline pretty well when we close most of the spaces. That's the beauty of the test. However, the profile improvement at this time was not good enough. Although there was still some spaces over the upper right. When we tried to retract with upper posterior test, you may notice here, there was no overjet, insufficient overjet for upper arch desization. So I decided to put another 2 buccal shape tests to dislice the whole lower dentition so that I can get the overjet for upper arch continue to dislice. At the same time, I may need anterior tests for anti-bowing because when we try to dislice a lot, the bowing effect would be larger. So we need anterior tests for anti-bowing. After a massive amount of incisor intrusion and retraction, you may see the upper incisor became so short. It looks embedded into the gingiva. And here, because we retract so much, but the bone stay, it looks like exoastosis. So we arrange a periodontal surgery, a crown lengthening to restore the crown length, and alveoloplasty to smooth the alveolar contour. And here is the how she looked like at debonding. Here we can close all the spaces and restore the missing lateral with implant prosthesis. Zipperometric superposition showed a large amount of incisor retraction. And we can also notice the counterclockwise rotation of mandible to improve the chin projection. Here is the progressive facial profile change. This was the debonding. And 9 months after debonding, during follow-up, we may notice the soft tissue profile looked even better. I think that is because neuromuscular adaptation after we correct the hard tissue and the soft tissue adapt. So I think this case is a very good example to illustrate the beauty of interdisciplinary treatment. However, again, I'd like to share you another failure case. Although it looks like very similar situation, but only one missing. I mean, if you miss any details that is critical, maybe it will reach a failure. Regular protrusion, a large decay at the upper left with endodontic involvement. Of course, full bite extraction, and I would suggest full wisdom teeth removal. However, this lady asked me to extract the upper left first molar instead. After extraction, you may notice this is the start. We start the start of space closure. 3 months later, here is the archwall. Look quite strange, right? Not so straight. It is because there is some bowing. There is some bowing during our space closure. It is because the elongated wisdom tooth, which impede by the lower second molar. I cannot close the upper space because I cannot move the elongated terminal molar forward. There is some occlusal interference between the wisdom tooth and the lower second molar. That's a big problem. So in addition to this buccal test, I inserted another plateau test here, but also bound a segment to accept the intrusive here. But I need to install another mean screw distal to terminal molar, because this is a cantilever. The distal end is not so easy to be intruded. If I do not have a mean screw distal to the terminal molar, it will be difficult to exert the intrusive force. So finally, after this setup, you can see the molar started to be intruded, embedded into the gingiva. The wire look straight. Then I can start the space closure. But during the space closure, you can see all the other quadrants. The spaces were all closed. Only the upper left, still a premolar size space. And we can see some transverse bowing here. The buccal overjet was decreased to posterior crossbite. So I need the patient to wear the posterior crisscross elastics, trying to get rid of the posterior crossbite. Although the spaces were closed, but you may see the time was a long duration, more than 3 years. The patient started to complain of long treatment time. And of course, the dental midline tend to shift to the left. And I also need the patient to wear asymmetric interarch elastics. Finally, we can close all the spaces. The midline was maintained well. However, the buccal segment, you can see the buccal segment was still a little bit class 3. So I bound the button here and used the buccal test and the palatal test to protract the upper posterior quadrant, the upper left quadrant forward. And finally, I can finish this case at this time. That is over 5 years, over 5 years. Here, OPG looked fine. But this is not what I want. I want to make the tough case treated easy, not make the good case gone bad. So the diagnosis and treatment plan, I think it is the most critical point. What did I do wrong? I think molar intrusion should be easy with the help of tests. However, you need to know if the terminal molar is not so easy to be intruded. I hope you will learn my lesson without trying by yourself. So my next 2014, it was 6th WIOC in Anaheim, in the United States. I spoke on interdisciplinary treatment with tests for mutilated dentitions. Here we have a mutilated class 3 malocclusion, anterior crossbite. And you can see 1, 4, 4, 6 were missing. 2, 5 residual roots. And these 3 were hopeless. So I decided to remove 3, 4, this one, to correct and correct the anterior crossbite. I decided to extract this one and this one to correct anterior crossbite. In addition, I plan to remove the wisdom teeth of these 3, except this one, because I try to maintain 2 molars in each quadrant, 2 molars in each quadrant. So the treatment plan was like this: close 1 premolar space at each quadrant and correct anterior crossbite. The space left in the end would be restored with implant prosthesis of these 3. Because the treatment plan involved a premolar extraction here, so I tried the premolar auto transplantation to replace 1 dental implant. So here is the initial setup. I used the posterior test to digitalize the lower dentition. Here is the bitable when I bonded the upper dentition because I try to avoid the bracket interference. So this is the time for auto transplantation at the 5th month. So before I extract the donor, I drill a hole. I raise the flap and drill a hole here, and I extract the premolar and try it in. Then we suture the flap with the wire and bracket to stabilize the auto transplant here, and use the periodontal dressing. Within 2 weeks after surgery, we arranged the root canal treatment to avoid the endotoxin released from necrotic pulp. So after that, here is the auto transplant. After that, we insert the open coil spring here to create the space for the upper left lateral incisor, and keep the space closure, keep retracting the lower anterior to correct the anterior crossbites. So here we correct the anterior crossbite. After we create the space, we can hand the aesthetic puncture here. And here is the last space left. So that this space is for dental implant installation. So the other specialists started the guided bone regeneration, implant installation, and the connect tissue grafts step by step. And finally, we can finish this case like this. One auto transplantation and 2 dental implant. Here is the Zipperometric Superposition. We can digitalize the lower incisors to correct the lower lip protrusion and finish this 4 mouth rehabilitation by 1 auto transplant and 2 dental implants. And here is the follow-up, 3 years, 8 months. And here is the periapical film of this one, the auto transplant. So for this kind of 4 mouth rehabilitation, if we can include the interdisciplinary treatment, we can have this kind of auto transplantation to preserve the patient's extraction tools to continue the use. But not every case is as successful as the previous one. I'd like to share you again a fatal case. Here we can see a protrusive case with the gummy smile. And in addition to lower right first molar, the lower left were 2 missing. One missing was the second premolar and the first molar. So the treatment plan is upper bicuspid extraction, upper first bicuspid extraction, and upper wisdom teeth removal. Close 1 space in the lower arch at each quadrant, then 1 dental implant. But with the concept of auto transplantation, we can transplant 1 premolar to the place of the dental implant. So here we go. We can see after initial alignment, then we can we do the auto transplant here. However, this one was not successful because of gummy smile. I insert the anterior test, upper anterior test for gummy smile correction. And I started the space closure in the lower arch. However, you may see the angulation of the second premolar look not so good. So I cannot use the regular sliding mechanics that I use to close the spaces because there was some friction. So I use the closing loop to close the spaces and finish this case like this. Actually, this patient was happy because of the profile improvement and the gummy smile correction. If we look at the Zipperometric Superposition, it looks good. And here is the OPG. But if you look at the angulation of the auto transplant, you may notice the angulation seems not so good. It is because I got the ankylosis. The reason why I failed in this case, I think there might be some reason. The first one might be the alveolar ridge actually not wide enough to accommodate the roots, to accommodate this root. And the flap adaptation is not good enough. And then the wire was not passive. So the bonding position of the bracket and the wire, the combination of the wire and the bracket relationship was not good, was not so passive. So that I got this case to be ankylosis. And one thing which is more important, at least I chose the right site for the auto transplant, because once it was ankylosed, I cannot move it at all. But luckily, we can finish the occlusion like this. Although it was ankylosed, we cannot move these tooth, but we can finish all the other teeth in compatible position with this ankylosed tooth. But we need to know the prognosis of the ankylosis. It due to resorption, the replacement resorption. So I had better to watch it very carefully to follow up this case. The periodontal pocket looks good. After more than 6 years, still looks good. But the periodontal membrane looks not so clear. There might be some resorption. So I learned my lesson. And in this case, a multiple missing in the lower arch, but the severe corroding in the upper. So I decided to do the auto transplant from here to here, from here to here. So this is the first one. The upper to the upper right to upper to lower right, the upper left to the lower left. But please notice this one. I rotate this premolar to mimic Canine. And more importantly, I rotate the transplant to be accommodated in this narrow ridge, because the ridge is not so wide. So we had better rotate a bit. And after the auto transplantation, we can close all the spaces and finish this case like this. Facial profile, no problem. Occlusion, basically okay, although not perfect. But patient was happy. And we can see the OBG looks good. And here is 10 months follow-up. Here is the periodical film at follow-up. We can see the periodontal membrane clearly, lamina dura very well. So after the WIOC in Anaheim, because that was in United States, so Dr. Greg Huang and Dr. David Turpin, they were among the audience. So I got the invitation for the next AAO meeting in San Francisco in 2015. So I spoke on Tough Case Made Easy with tests and interdisciplinary treatments. This time I tried to focus on some borderline case treated non-surgically. The first one is a very protrusive case with gummy smile, but very upright upper incisors, which makes the upper incisor retraction very difficult. But with the test, the combined intrusion and retraction force system, I retract the upper dentition and intrude the upper incisors to correct the gummy smile, along with the torquing spring, we can control the upper incisor torque. So this is the Anchorage Setup, the combined intrusion and retraction force system. We can close all the spaces. Here we can see the exoastosis. We need the periodontist to help us to remove the exoastosis and smooth the alveolar bone, and also restore the appropriate crown length so that we can improve her facial profile and also correct the gummy smile. And here is the Zipperometric Superposition. You can see there was no anchorage loss at all, and we can have the incisor intrusion and retraction. And this was traced by Dr. Ronsi. I'd like to take this opportunity to thank him again. But the next case, I'd like to share with you, although the basic combined intrusion and retraction force system works very well to reduce the protrusion. But as sometimes you may feel that you want to distalize more. Like this case, because of the thick lip, you may expect the profile response might not be as good as regular case. So 4-bite extraction, combined intrusion and retraction force system as regular. When we close most of the spaces, although there was significant profile improvements, but still you want more. The patient was not wants more retraction. So I decided to install 2 buccal shelf tests to maximize the lower retraction so that I can keep retracting the upper dentition. And here is the progress. Well, here is the final results we can achieve. A better profile improvement in comparison with the, when we close all the spaces, there was still some protrusion. But if we can install the lower test, then we can design lower arch so we can get enough overjet for upper dentition to retract more. And here is the Zipperometric Superposition. Combine intrusion and retraction force system on both arches to maximize the profile improvement. Okay, maybe I bypass this part. I just want to emphasize, if you can use the combined intrusion and retraction force system on both arches like this, then you can continue to improve the facial profile from here to here. And the key point is buccal shelf test. Buccal shelf test. And another point would be incisor torque control. Because when you distalize a lot, if you cannot control the incisor torque well, there would be a big problem. But again, I arranged the next case to be a fatal case. Because this case, you can see she was so severe protrusion. Even 4 bicuspid have been extracted. But the patient asked for retreatment after her first orthodontic treatment with 4 bicuspid extracted. Actually, I was excited to see the lower first molar. The condition were not good. So I proposed to remove these 2 lower first molar and upper wisdom teeth, because I think I can retract the lower incisor with the molar space, and I can use the upper posterior test to distalize the whole upper dentition. So here is the progress. Although I can distalize the upper arch during the space closure, but the overjet, still, I cannot get ideal overjet, because we know there are boundaries for tooth movement. There are limitations. So in the end, I need to install the buccal test and protract the low molars to finish like this. Occlusion-wise, it was good. The facial profile improved significantly, but the things did not proceed as my expectation. The OPG looked fine. The Zipperometric Superposition showed a large amount of upper dentition distalization, but I cannot retract it all the way. I need to protract the low molars with the buccal shaft test to protract the low molars to finish this case. And here you can see the progress, the progressive facial profile change. This is pre-treatment, 2 years, 4 years, and almost 5 years. You can see the facial profile changes. Actually, patient was happy, but I think the experience actually quite horrible, because you do not know whether you can achieve your treatment goal or not. You need to have a plan B when you try this kind of extreme case. Extreme sports is usually quite dangerous. You need well prepared yourself for this kind of trial. But when I come across this case, I changed my treatment plan. Again, he is a retreatment case. You can see the upper first premolars have been extracted, lower non-extraction. But he complained of protrusion and retruded chin. So we decided to remove lower first premolars, low first premolars. But this time, I chose upper second molar, because I think if I have a spaces, if I have a second molar space, then I can distalize the 6 to 6 uneventfully, because I got a space there and I can have tests for maximal retraction. But actually, I added the lower buccal test for maximal retraction, because you can see the overjet was minimal. If I cannot retract the lower more, then I cannot retract the upper. So this is the force system. In this case, combine intrusion and retraction force system on both arches to maximize the retraction. 15 months into treatment. Here is the profile change. Not too bad, but we can continue the forceps to achieve this kind of profile improvement. The Zipperometric Superposition showed a massive amount incisor intrusion and retraction. And because of the occlusal plane of the upper arch was moved upward so that we can get counterclockwise rotation of mandible to rotate the pogonium forward to improve the chin projection. Here you can see the space closed at 15 months, and in the end, here it looked different. It was because total arch desization continued, and counterclockwise rotation of mandible improved the chin projection. So the next is another journey to Angle Society. It was Dr. Greg Huang who invited me to join the Angle Society. He told me that a good friend, Dr. Tae Kim, was also a member there. And what I need to do is to bring 3 completed cases and treat 5 cases prospectively. So 2016, I went to Portland for angle meeting, for my first angle meeting there, and enjoyed the conference very well. So I decided to treat 5 cases prospectively. And here is my case number 1. I chose this case because actually this was not a very difficult case. Canine impaction on the plateau side. So the patient asked me to reposition this canine back to its original position. So I exposed this canine and I retract this canine with the plateau test. And here is the comment from the admission committee. And the comment is, I do not think there is a big risk with the root damage to the maxillary left lateral incisor. If it is posed vertically into the palate first before being moved labially, it will end up in good position. So after I retract it, expose a little more, then I start to protract it to the buccal. But at this time, I check a CBCT to find there was barely, almost no bone on the actually labial side of the canine, the labial side of the canine. So what should I do? During the progress of my angle case, I went to India, Goa, for 8th WIOC in 2016, and I spoke on transposition. And here is a canine transposition case, bilateral canine transposition. So when I try to correct the transposition, I retract this lateral incisor first so that I can give way for the canine to distalize. So I utilize the plateau test for plateau movement of the lateral incisor. And the next step, I need to move the lateral incisor to mesially. So I use the power chain to move the lateral incisor. However, if you look at the CBCT here, you may find here the root was still transposed with the lateral incisor. I mean, the root of the upper right canine was still transposed with the upper right lateral incisor. Although it looked fine clinically, but actually underneath the root was in close contact. We need to move the roots to move away from the root of the lateral incisor. So I decided to bond the lever arm to mimic the root of the canine and move the roots first, then I can correct the transposition. Not until the roots were clear of contact, close contact. And finally, you can see after I confirm the root clearance with the CBCT, then I can move the canine back to its ideal position. But still, if you look at the CBCT, you can see the root, the direction of the root was almost horizontal, which require a long term to move the roots upright on the on its original angulation and position. So it took 5 years to correct the transposition. In this case, you can see before and after. Here is before and after. OPG looked fine, and both the canine transposition were corrected. And here, so if you ask me the key point for the final success, I will say one of them is the lever arm to pass the force through the center, near the center of resistance. And another key is CBCT. I think that is the light at the end of the tunnel. Otherwise, you do not know the condition, the relationship between the roots underneath. And every time, a good friend of mine, Dr. Chris Chan, he always say, believe me, it's easy. But actually, I need to say, believe me, it's easy to end up failure, because I'm going to share you another failure case. You can see the extracted canine, a severe root resorption like this, and that is because root collision. Again, you can see a canine here. After exposure, start to track the canine. It looked not bad. Here, we start to rotate the canine from here to here. Initially, we bound the lateral, but somehow we feel that there might, it would be better to have freedom for this lateral incisor when we move this canine. If there is some root contact, there is still some freedom. So we release this canine, this lateral incisor. But when we try to rotate this canine, something happened. You can see severe gingival recession like this. So I was frightened, and I decided to stop and try to move it back to introduce this into the soft tissue gingival and try again. But at this time, I took a CBCT, and I noticed here the root, the relationship of these two roots are still in close proximity. And if we look at the panel, there was still a cross. So finally, I lost this canine. When I removed the canine, it looks like this, a severe root resorption, a result of root collision. So what would you do for the next? Finally, after a struggle, a couple of months, I decided to use a Plato test with the spring to hold the incisors and protract the buccal segment forward to close the space, and finish this case like this. Right side class 1 and left side class 2. So what would you do for my angle case 1? My angle case 1. I decided to do the auto transplant. I decided to try the auto transplant before it was too late. Before it was too late, because I think if I wait, maybe after the gingiva was started to recede, it might be too late. So I decided to try auto transplantation before it was too late. And I finished this case like this. It looked not too bad. All, of course, except the canine, all the others look so simple. But that was patient's chief complaint. So I decided to try the auto transplantation, and it works well. And I finished my auto transplantation in this case, so that I do not lose this canine. And here is the comment from the admission committee. Without CBCT, most of us would have continued to move the canine into the arch and finished without realizing and had a loss of the canine. So I think it's quite important to read the CBCT in this difficult case. Okay, so here is a case transferred by a colleague because of ankylosis of the canine. Here is a radiograph, and clinically, I rebound the bracket and try to make space for the canine and try to use tests to extrude the canine, but in vain. I think it might be ankylosis, but I still want to try to retract this canine with a test. But finally, I raise a flap, then subluxate this canine and start elastic traction. And finally, I see some tooth movement of this canine, and I think it's possible for us to move this canine. Of course, all the rest, everyone can see how it is going, just regular orthodontics. So the key for this ankylosis, I'm not sure whether it is ankylosis or not, but create space, open a flap, try to tract and open a flap, try to subluxate, then move it, and that is the key to success. But not every case was so lucky. What if you come across a real ankylosis? This is a regular protrusion case. So 4-bite extraction and wisdom teeth removal, then space closure with maximal anchorage with test. But one thing happened. We noticed the overjet was become larger and larger because we retract the lower, but we cannot retract the upper. And the arch form became weird. So I changed to the closing loop, but still I cannot close the space, although the space became smaller, but we can notice the anchorage loss of the upper posterior teeth. So we can confirm there was an ankylosis in the front. after trying to know which one is the ankylosed incisor, then we decided to bypass the incisor and retract all the buccal segment back to the ideal class 1 occlusion. Then we open a flap, cut a single tooth osteotomy, and move this segment back to its ideal position, and using bracket and wire to stabilize this segment, and finish this case like this. Single tooth osteotomy is the key. Of course, before that, you need to diagnose this, which one is ankylosis, and you need the test to digitalize the buccal segment to its ideal class 1 relationship, and at last, single tooth osteotomy to reposition this ankylosed incisor. Okay, the next is WIOC in Kobe, Japan. And 2018 AAO in Washington, DC. I spoke on orthodontic correction of adult gummy smile with tests and the periodontal surgery. And here we can see some gummy smile correction successfully, but I like to show you the most difficult one because she was definitely a surgical case. And she refused to receive orthodontic surgery. So with the understanding of compromised treatment results, we remove 4 bicuspid and wisdom tooth, then combine intrusion and retraction force system on both arches. Here you can see again, the arch wire at the terminal did not move upward. So I decided to install another test, digital to terminal molar, and also a plateau test on each side to focus on molar intrusion to close this open bite, So with the molar intruded, we can close the bite gradually and finish this occlusion. And here is the treatment results. But if you may notice here, after a massive amount of retraction, there was so robust available. We need a periodontal surgery. OPG looked good, and the Zipperometric Superposition showed a large amount of incisor intrusion and retraction. And if you look at the Zipperogram superposition, intrusion everywhere, so that we can get the counterclockwise rotation to improve the chin projection. Low facial height was reduced, mandibular angle was closed, and the Pogonian was moved upward and forward to improve the chin projection. So here is the mandibular angle reduction from 49 to 45. Here are some numbers. For this kind of extreme case, actually, the treatment goal is to reduce the hard tissue volume anterior, posteriorly, and also vertically. If we close all the spaces, it looks like this. But if we can further control the vertical, it will improve a little bit more to relieve the tension. You can see the chin projection improve progressively. And here is the before, after follow-up, and 3 years follow-up. But some case, on the contrary, for this low angle case, although the incisor show not bad. She complained of protrusion. So we just use combined intrusion and retraction force system as usual to close all the spaces to improve the facial profile, but the patient started to complain insufficient tooth show, although she was satisfied with the profile improvement. That is 10th WIOC in Bali. I learned something from some other masters. The upper incisor extrusion and the lower incisor intrusion for cases with insufficient tooth show. So here I try this anterior test extrusion and lower incisor intrusion for this case to finish this patient like this, and she was happy for the regain of the incisor tooth show. And here is the progress. The start, she complained insufficient tooth show, and then we apply the anterior test extrusion and finish. And here is some setup of this technique. And that is the beauty of the international conference experience, that I can learn a lot from some other colleagues, so that it inspired me in my cases. I shared this in my 2019 TAO annual meeting with the anterior test extrusion. Here we can see even more lower angle cases like this. I start, for sure, you will not want to extract in this kind of low angle case. So I use upper posterior test to distalize the upper arch, trying to correct the class 2. And I also, because I cannot distalize all the way, so I use slanted buccal test to protract the lower dentition. And after that, I start the anterior test extrusion to improve her incisor show. It seems a little bit improvement, but I want to try it again and finish this case like this. The improvement looked significant because of anterior test. We can extrude the upper incisors so that she look even better. The next was 2019 AAO in Los Angeles, and the next 11th WIOC in Bucharest, Romania. I spoke on application tests in ortho implant combined cases. Here is an example I'd like to share with you. For this protrusion case, for sure we will extract 2 upper bicuspid. And for the missing in the lower dentition, we may need use the combined intrusion and retraction force system on both arches to arrange the space like this. And in the end, we will need 2 dental implants on each side to restore the missing. So the force system would be distal force to retract the upper dentition. As the line of action is way below the center of resistance, the anterior tend to dump anteriorly. The anterior tend to dump, so we need an upper anterior test to anti-bowing. And at the same time, we will generate counterclockwise moment to maintain the incisor torque. Besides that, the torquing spring was also used to apply the plateau root torque to control the upper incisor torque. To level the curve of speed, we used lower anterior test. And to upright the low molars, a segment of open coil spring was inserted in front of the molar. So the force will above the center of resistance and tip the molar back. And the reciprocal force will tend to flare the lower incisor labially. So we use the lower posterior test to distalize the lower anterior and prevent the lower incisors from flaring. At the same time, you may see the dental midline was off. The right side was class 2. So I asked the patient to wear the asymmetric interarch elastics for midline correction. And it's time to install the dental implant. So I talked to the implantologist to install the fixture 1 millimeter off to the regular position, 1 millimeter distal on the lower left, and 1 millimeter mesial at lower right, according to the planned tooth movement, because we try to correct the dental midline by pushing the lower anterior to the left. So here I got after the implant installation, and afterwards, after a couple of months for osteointegration, the prostheses were fabricated as soon as possible. And I was soon informed, I was asked to intrude the upper molars because there were insufficient interocclusal space for the implant prosthesis. So I installed the plateau test to intrude the upper molars and insert a segment of open coil spring here to push the right buccal segment to the left side to correct the dental midline. So, so after a couple of months, the dental midline were coincident, and the occlusion of the right buccal segment improved quite a bit, and we can finish like this. The facial profile were improved, and the interdisciplinary looked good. And here is the before and after. Before and after. And this was a good example using the dental implant as anchorage to fine-tune the final occlusion. And here is the Zipperometric Superposition to show you the profile change, the amount of incisor retraction. And afterwards, we need alveoloplasty to remove the exoastosis and also restore the crown length, appropriate crown length. And here is the final results. So talk to your implantologist and communicate with them for the ideal position of the dental implants. And finally, I'd like to share with you my final case, interdisciplinary treatment for mutilated dentition with mini implants, dental implants, and auto transplants. This lady, asymmetry, severe protrusion, occlusal plane canting. And you can see, in addition to gummy smile, the gingival line was also canted, and multiple missing in the lower arch. That's why she was a mutilated dentition. In consideration of her facial profile and skeletal disharmony, actually, the treatment plan, the ideal treatment plan would be 1 premolar extraction space in each quadrant, then close all the spaces and orthodontic surgery to correct the skeletal discrepancy, then dental implant to restore the missing. However, the patient declined the surgical approach, and she also asked for minimizing the number of dental implants. So finally, we decided to close one space at each quadrant. Close one space at each quadrant. Then the space left was also restored by auto transplant here and here. So in the end, there would be one dental implant only, one dental implant only. So this patient was happy with this treatment plan, with one dental implant, 2 auto transplant. So here we go with the upper posterior test to start the retraction of upper arch and anterior test for bite opening. And in conjunction with the upper right posterior test, the occlusal plane was correct. The occlusal plane was correct as possible. Here we have the first auto transplant from the upper right second premolar to the upper left second premolar. And here is the second auto transplant we are going to receive from the lower left wisdom tooth to the lower right first molar. So here we have the second auto transplant, the first, the second. So we keep the space closure, and here is the last space for the dental implant. So after implant installation, provisional fabrication, and here is how she looked like at debonding. Although it looked a little bit strange with 3 premolar at lower left, but the overall occlusion looked not bad. And here is the final treatment results. The occlusion-wise, it was good, and for the profile change, she was very satisfied with the profile and the aesthetics. You can see the gummy smile was corrected, although the asymmetry remained, but because we hide the gingival line above, so it was not obvious for the occlusal plane canting. So we solved this 4 months rehabilitation with 2 auto transplant and 1 dental implant. And here is the follow-up of these 2 auto transplant. It looks not bad. And the Zipperometric Superposition, we can see a large amount of incisal intrusion and retraction. And because of the intrusion, we can solve the gummy smile. And we also move the occlusal plane upward so that we can get the counterclockwise rotation of the mandible to improve the chin projection. Here to here, you can see the improvement of on the aesthetics. And here is the 7-year, 8 months follow-up. Still look very good, and the auto transplant also look stable. So after the WIOC last year, 2019 in Bucharest, Romania, and annual meeting last year in Portland, everything was locked down after the COVID-19 pandemic. So after a couple of months, I was invited by Orthodontic Mastery Group on Facebook, and also IOS, Indian Orthodontic Society. The first 2020 in-person conference was TAO annual conference in December, the first in-person conference. But I prepared the talk today. I mean, I prepared the content I took today. but actually I cannot finish the content in my time slot. So I'm very happy to have this opportunity to share with the colleagues today with the orthodontic turning point from failure to success. It is my pleasure to share some of my thoughts with you. You can, like this, non-extraction in low angle case, but what would you do if you cannot achieve the total arch desization in the upper arch only, or non-extraction treatment with tests in class 3 cases and the bimacular protrusion case? But what if the large space, very difficult to close? I share with you the difficulty I come across. So everything might be a best solution, but I like you to save your time in try and error. If there is someone who has done the same error. So here is my presentation today. I hope you will enjoy my talk. And if you have any question about these materials, I will leave my email there. You are more than welcome to communicate with me. At last, I'd like to thank all my colleagues, because one is too small a number to achieve greatness. And we have so many orthodontists working together in my office. Besides the orthodontists, we also have some other general practitioners, prosthodontists, periodontists, working together as a team. I also like to thank all my family, my beloved wife and 3 daughters. And especially, I like to thank my better half, flying together with me to be so supportive wife and give me free wings to fly. Thank you for your kind attention. Here is my email, and I hope everyone enjoy, and please ask any question if you have some